mute so we can make sure that we're able to hear. Laura, I think you have to stop sharing
Yes.
so I can.
Sorry about that.
No worries. A wealth of knowledge on this call. Welcome, everyone. Perfect, perfect. Alrighty. I'll share again. And can you see it, Laura, without any issues?
Yep, you're good to go.
Okay, perfect. Hi, everyone. Like she said, my name is Rachel Dumas. I am a registered nurse. I actually just finished, and my master's degree was conferred yesterday. So I am a master prepared nurse in nursing informatics. So excited about that. It was a long journey to say the very least. But we're not going to get into that today. Here I am working as a nurse and a maternal health advocate, and also a mom. And I'm presenting here today a very unique case, and we are going to navigate this case, a lived experience of a mom who experienced 9 pregnancy losses. And this is going to be the first presentation, or maybe the first presentation, where I am encouraging you to pull out your phones and be on your phones the whole time. So let's get started. So the point of this presentation is to raise awareness, advocate for change, and take action. So I hope if this presentation does nothing else, it empowers you and inspires you to take action as healthcare professionals, as advocates. And many of you, unfortunately, may resonate with the story itself from your own personal experience. But regardless of what parts of the story you identify with, I hope it inspires you to take action so that we can have better maternal health care outcomes in the state of Georgia and even nationally. So, rules of engagement, participation. Like I said, I want you to be on your phones. There is going to be a scenario that is presented to you for each pregnancy that this patient endured. I will go through pertinent information, and then you will make their care option that you felt would best fit this patient's scenario. So you are the interdisciplinary team. You're the nurse, you're the doctor, you're the social worker, you're the mental health professional, you're the partner, you're everyone today. And we will work as a team today to identify what should have happened. After everyone has voted using the QR code that's provided on the screen or the text code, you can use either one. I find the QR code just easier to navigate. We will then talk about what actually happened with this patient. And due to the time limitations, I had to pre-select care options. So I'm so happy to have a Q&A at the end of this presentation. It takes about 35 minutes to get through the presentation. So if you felt like more options should have been, or different options should have been allotted, please feel free to give me that feedback as well. So let's get started. And this is one patient. Our patient is a 28-year-old African-American female with a very insignificant, history, just asthma, tonsillectomy at 8. She has a familial history of loss, unbeknownst to her until mid to late pregnancy journey. Her mom had 2 stillbirths and a miscarriage, and her aunt had 7 full-term stillbirths. She completed an appointment with the OB after getting a positive home pregnancy test. She did a vaginal ultrasound, and she was told that her first pregnancy ended in a miscarriage. So here we are with our first care options. I'm going to make this QR code just bigger for you all. So please scan this code right here in bold. You can pick multiple options. I encourage you to because a lot of these require multiple options. But what care options do we believe fits the needs of this patient? Should we just reassure her that miscarriages are a normal part of pregnancy journeys and she'll go on to have a easy pregnancy journey in the future and be able to carry a baby without any issues? Should we offer mental health and emotional health support because she could be grieving? A loss is a loss, right? Should we at this point complete additional testing to try and rule out possible causes of a miscarriage early on? What are we thinking? So I'm seeing a lot of C and D. C and D. Okay, perfect. So definitely something that doesn't happen often after you have your first miscarriage is additional testing. It is very rare that you have follow-up visits or additional testing. And what you can do is test the thyroid to see if that is a cause of a miscarriage, autoimmune diseases, antiphospholipid syndrome. So many different issues can be tested early on so that we can identify, early in the pregnancy journey, if this mother is, susceptible to miscarriages. And then we love to, as healthcare professionals, just not give mental health and emotional health support resources after the first miscarriage. It's almost like we're very nonchalant about it. At some time, at some point, we have to address this and see if the patient and assess the patient and see if she would like these resources, because sometimes these patients take this very hard and may need to see a mental health professional because of grief and anxiety and depression because of a loss. And I'm here to tell you that this patient was told that this is a normal part of the pregnancy journey and that she would go on to have a baby without any difficulty. She was not given any mental health resources, and there was no additional testing that was completed. So here we are, pregnancy number 2. It is August 2020. 2020 coronavirus was live and well, so it's a scary time to be in a hospital or in any medical setting for patients and healthcare providers. However, the patient had another positive pregnancy test, and this time she goes to the ER because she's bleeding, and it's heavier than the last time in 2018. The ER doctor did a vaginal ultrasound and told her that she's having twins. He also told her that he saw a subchorionic hemorrhage, which is typically reabsorbed by the body, but to follow up with the OBGYN for close monitoring. By the time she followed up with the OBGYN, the bleeding was worse. She began to have 10 out of 10 abdominal pain, vomiting, nausea. She knew something was wrong. She was diagnosed with a quote unquote threatened abortion, which is a potential miscarriage. And her OBGYN told her everything was fine. She did the usual genetic testing at 9 weeks. She was in and out of the ER because all of the symptoms just intensified. And at 13 weeks and 3 days, she lost the first baby. What are we doing for our patient? At this point, should we refer them to a maternal fetal medicine doctor? Because she's still pregnant, right? She only lost one baby. Should we do a full diagnostic workup to rule out the causes of the bleeding and the pain and the other symptoms that she's experiencing? Should we just tell her to go home and just rest? Should we complete additional testing to identify the cause of the 2 miscarriages that she had? Agreed. I think this is a good time to see a maternal fetal medicine doctor. They closely monitor the fetus, and she would get that extra layer of care that she needs considering she just lost one of her babies. Um, she's still bleeding. She still has severe pain and other symptoms. And she just had two miscarriages, one in 2018 and then another one with this pregnancy. I think it would make sense to, you know, see what was going on that's causing these. If we can find a cause, they're not always easily identified, but we can at least try and see. Unfortunately, this patient was just told to go home and recover. Fortunately, her symptoms resolved. In October 2020, she completed a second ultrasound to just make sure that she completely, lost that baby and there was nothing, none of that pregnancy being retained in her except for the twin. It will be confirmed that, and the symptoms resolved. She did an ultrasound and the OB said everything looked great. However, at 15 weeks, a little over 15 weeks, she woke up wet. And a few hours later, she went to use the bathroom and the baby fell in the toilet. She goes to the emergency room at this point. When she goes to the emergency room, the ER doctor asks her, "How did you even know that you were pregnant?" This is the same emergency room that she's been to numerous times. What are we doing with this patient? Should we encourage her to just focus on her physical recovery? Should we complete labs, ultrasound, administer the abortion pill to make sure the pregnancy and the placenta is fully evacuated? Maybe consider a DNC. Should we advise her to follow up with the OB? Should we order palliative care consult for supportive care, for a care plan for her lost baby? Should we assess home support, right? She's going to need support at home. We should assess SDOH needs and also give her mental and emotional health, support at this point. Should we refer her to a specialist at this point? Should we consider reproductive endocrinology and a reproductive geneticist at this point? So I'm seeing a lot of the lab draws, ultrasound, abortion pill, and the referral to specialists. I see some palliative care. I really want to talk about that because palliative care is so underused or just not used at all in maternal care, right? And considering 30% of pregnancies being lost, this is so, such an underused service. And we need this service. Palliative care not only offers support for end of life care, which we need in maternal health, right? Not only do babies pass, but also mothers. But we also need them for supportive care. When we do a palliative care consult, we think of terminal illness or ICU patients a lot of times, or those who may be, in the process of dying. However, they also offer support through complicated medical journeys. And if I have a patient who's in and out the hospital as consistently as this patient is, palliative care may be a great resource for this patient. So it's just something to think about. So this patient did receive the lab draws ultrasound. She was administered the abortion pill as well as some morphine to help with the pain. And she was sent home for physical recovery and follow up with the OB. Upon following up with the OB, she was diagnosed with cervical insufficiency. So her cervix is too weak to carry a baby full term, and she typically will lose the baby at the end of the first trimester, beginning of the second, which is when the baby has enough weight to put pressure on that cervix for it to silently typically open up. So a lot of times it doesn't open up with contractions, it just opens and you miscarry. She was told that she has to make it to 13 weeks to receive a transvaginal cerclage. The issue is she had early miscarriages as well. She had one in 2018. She had two after this pregnancy, and she notified the OB, but nothing was done. But what should be done? Should we just reinforce to the patient, hey, just make it to 13 weeks? Should we address the emotional and mental health concerns, considering she, at this point, is experiencing recurrent pregnancy loss? She lost twins, and then she had another miscarriage a couple of years earlier. Should we discuss additional cerclage options? Being told to make it to 13 weeks is telling the patient that you're going to get a transvaginal cerclage. Because if she was being considered for a transabdominal cerclage or abdominal cerclage, that can be placed outside of pregnancy, which wasn't an option that was given to her. Should we consider palliative care? Should we consider a specialist referral at this point? Awesome. Yeah, so the issue was this patient was told make it to 13 weeks, and that was all. That was it. So here we are, April 2021. She's talking to her friend who has an OB clinic, who is a nurse practitioner, and her friend puts her on progesterone suppositories. She is told that she needs to start taking them as soon as she gets 2 lines on a test. She is at work, and her manager advises her to see a reproductive geneticist and a reproductive endocrinologist. And she agreed. So she asked her OB to give her a referral to both of those doctors, and her OB did. She had a full evaluation of her uterus. She had a saline sonogram to better visualize the shape of her uterus to see if that is perhaps causing the miscarriage. She was worked up for thyroid disease, autoimmune diseases. She went to the reproductive geneticist. There was no genetic component per the testing that was causing the miscarriages and the stillbirth. I'm sorry, the miscarriages. And she makes it to 13 weeks with the progesterone suppository. She's followed by the reproductive endocrinologist for the first trimester, and then she graduates to the maternal fetal medicine doctor. The transvaginal cerclage is completed. The MFM told her to come back in 7 weeks. And because of her history of loss, the patient is very uncomfortable with that. She tried to advocate for herself to come back sooner than that. She asked to come back in 2 weeks or 3 weeks, and she was told that if the cerclage was failing, that she would have excruciating pain and bleeding, and to not worry. The patient said, okay, but what should have happened? Do we, as healthcare providers, just reassure her that 20-week appointment is fine? That's sufficient. Should we educate her on symptoms of, I can make this bigger, of a failed cerclage so that she could self-monitor at home? Should we actively listen to this patient and schedule her for an early appointment, considering the amount of loss that she has? Should we provide emotional and mental health resources? Should we refer her to additional specialists at this point? Yeah, I definitely agree that we should listen to our patients, and if they're advocating for earlier appointments, then, there are constraints. Insurance for sure is an issue, but at the same time, if you have a patient with recurrent pregnancy losses, right, 7 weeks is a long time. It's a very, very long time. And then on the patient's end, she was told multiple times during her previous pregnancy with twins that everything was fine, and she lost both babies after being told everything was fine. So to hear that, we can only imagine what the patient is feeling and what the patient is thinking. However, she was reassured that the 20-week follow-up was sufficient. Here we are, 20 weeks. We're at the MFM. Patient feels great, no symptoms, no bleeding, no pain. Mid ultrasound, after being told that the baby's heartbeat is strong and everything looks great, the ultrasound tech walks out and the MFM walks in, the one who did the surgery, and she informs the patient that the cerclage in fact failed, despite of having no symptoms. This patient tried her best to advocate for herself. She asked to be put on bed rest. She asked for revision of the cerclage. The doctor told her, you can go and check into maternity triage and have your baby. Shocked, the patient asked, wouldn't a baby die at 20 weeks? And the doctor said yes. What should we do for this patient? Should we acknowledge their advocacy efforts? Discuss other pregnancy saving options? Should we at this point call a meeting with the interdisciplinary team to see what's best for this patient? Because now she has a reproductive endocrinologist, a maternal fetal medicine doctor, she has her OB, you know, should we call a team meeting for this patient? Should we consult palliative care? Because we have to think about this. The doctor is telling her to go deliver a baby at 20 weeks. That baby is not going to survive. We have a potential loss on our hands. This would be a good time for palliative care to open a care plan, regardless of what happens. Should we provide emotional support, mental health support resources? Or should we reinforce what was said and tell the patient go to the triage and deliver the baby immediately? Definitely agree with the first four. Unfortunately, this patient was reassured that the best option was to deliver that baby immediately. However, the patient didn't give up. Instead, she left that office in tears. However, she did some research. She found some peer-reviewed articles regarding failed transvaginal cerclages and saw that there were instances in which a abdominal cerclage was placed in an instance of a failed transvaginal cerclage, and it saved the pregnancy. Furthermore, she called her village, her coworkers, her friends, her family, everybody, her other doctors, and told them what happened. And they found a doctor who would do it in Texas, Dr. Fogwell at Texas Health in Dallas. He called her that night. She told him everything that happened, sent over records, and he told her to fly to Dallas because the drive would be too risky. So, risking having a baby fall out of her on a plane, she flies from Atlanta, Georgia to Dallas, Texas, and she gets a transabdominal cerclage done. Unfortunately, because of the flight, the baby dropped more, and that 3-hour surgery took 8 hours to complete. However, she woke up from anesthesia and she was still pregnant. And she was sent back to the room. She felt good. However, when the anesthesia wore off, the contractions set in. And she was in labor despite of all of the tocolytics that were administered to her. She was in labor for 30 hours. And at the end of those 30 hours, her water broke. And she had to go back to the operating room, get both of the cerclages removed, get an epidural, and deliver that baby vaginally at a little, at maybe a day or two shy of 21 weeks. That doctor in Dallas told her that if that was to happen, that he would bring her back to Dallas and repeat that surgery outside of pregnancy at no cost. The patient, on her own accord, set up an appointment with a talk therapist. She proceeded to have 3 more early miscarriages. However, true to his word, she went back to Dallas, and at no cost to her, the transabdominal cerclage was placed. In addition to a DNC was done, hysteroscopy, and another procedure was done just to make sure that she wasn't retaining any tissue from the pregnancy losses. She continued seeing her therapist. She also saw a hypnotherapist a few times as well. What can we do for the patient at this point? Can we just recommend that she continue therapy? Should we tell her to try again when she's ready? She has the transabdominal cerclage at this point. Should we still consider a multidisciplinary team meeting at this point? We're talking about 9 pregnancy losses here. Should we provide additional emotional support and mental health resources? So the patient was told to just go and try again. Now that you got your transabdominal cerclage. So here we are, May 2022. Baby number 10. Pregnancy number 9. She has a home positive pregnancy test. She is monitored by reproductive endocrinology. She graduates to a different maternal fetal medicine doctor at 13 weeks. She is also followed by an OB throughout her pregnancy. But at the 3rd trimester, she begins to have high heart rate over the 130s, dizziness, shortness of breath, decreased oxygen saturation in the 80s. She's referred to a cardiologist who put her on metoprolol. It mildly helps. She went from the 130s to 180s to the 100s to the 150s. She had multiple ER visits. Her cardiologist sent her to the ER one particular night. The ER wait time was 10 hours. She was short of breath. Anytime she was vertical, anytime she sat up or stood, she could not breathe, and her oxygen would drop. During her stay, she completed a pulmonologist consultation, and was told that she needed oxygen. She was also told that if she didn't get oxygen and her oxygen level stayed low for 10 minutes, that she needed to have a C-section emergently. Now, if this patient is in Atlanta, I don't know I don't know about you, but I couldn't get from my front door to my mailbox in 10 minutes sometimes. I would have a C-section in 10 minutes from anywhere in Atlanta. But what should we do for this patient? Should we make sure she gets her oxygen before leaving the hospital? Should we make sure she follows up with her medical team after that stay? Should we address these prolonged ER visits at 8+ hours for patients with shortness of breath and deoxygenation? Should we complete education regarding how low oxygen impacts her and the baby? Should we develop a realistic distress plan for this patient? Yes, yes, yes. I see a lot of us are leaning towards the making sure she follows up with her medical team for close monitoring at this point. Absolutely. So this is a long road to say the least. Um, thank you for bearing with me, but as you can see in our healthcare system, we have a lot of work to do. And it starts with, well, it starts in a lot of places, from policies to workflows to compassionate care to culturally competent and culturally humble care to listening to patients. Something as what I would think would be simple was to listen to a patient and believe what they're saying, to patient advocacy training and understanding and listening to patients attempt to advocate for themselves. It's so many ways this patient was failed throughout her healthcare journey and her pregnancy journey, and it led to 9 pregnancy losses. She was never referred to a specialist by her own provider team outside of a cardiologist and a maternal fetal medicine specialist, and that was only for the cerclage. Her social determinants of health were not assessed, and that's so important. What if this patient was struggling to pay bills, couldn't afford her car note, was barely keeping her lights on, and we're expecting her to pay all these medical bills for all of these losses and then a baby? It is so unrealistic to expect patients to be able to even show up to some of these appointments, especially if you high risk. You have a significant amount of appointments, for a greater amount of appointments than you do if you have a healthy pregnancy. And sometimes you just cannot afford it. You just cannot afford it. And while we do have some Medicaid expansion policies in Georgia, that's not the truth everywhere. And considering this patient lives in Atlanta, why did she have to fly to Dallas, Texas to get treatment when you live in the middle of a city? She didn't live in rural Georgia. So there's a lot of work that needs to be done. And I know many of you on this call are boots on the ground doing the work, and I appreciate you so much for that. The last thing I want to mention is palliative care. I know a lot of us are healthcare providers, and I just want to bring this to your attention because, like I said, it's not used or it's underused in maternal care. But take advantage of palliative care consults. And the next time you have a patient where there's fetal demise, or the mother's life is at risk, or miscarriage, or anytime that there's a risk for a baby to pass, just consider consulting with palliative care so that they can get a care plan for that patient. It's an underused service, but that's what it's there for. We use it all the time for ICU patients and terminally ill patients and our cancer patients, but we don't use it for maternal health patients. So it's an untapped consultation that we need to tap into desperately. And I know you all are wondering what happened to this patient because I kind of cut it off quickly, but she finally had the baby on December 30th, 2022. His name is Nazaire. He was 4 pounds, 15 ounces, and she never got that oxygen. So she had a preterm birth. And this is the reason why March of Dimes gave us a F, which was worse than the national standard because of preterm birth rates. This we just saw full circle how it leads to these grades. But he's now a healthy 2-year-old baby. And as for the mom, if you'll allow me to reintroduce myself, my name is Rachelle Dumont. I am a registered nurse, a maternal health advocate. I am the founder of A Light After 9, but I'm also a 9-time pregnancy loss survivor and the mom of a potbelly 2-year-old baby, Nazaire. This is my story, and I hope that I am making an impact and change with this story because you may forget me, you may forget my name, but you will never forget my story. And if you can, scan the QR code and leave a review. And then I also put my information. If you know a mom who is struggling throughout a difficult pregnancy journey, please contact us on alightafter9.org or email me. I also love to present this to residency students, our medical students, our nursing students, social work doulas, just so they'll know what they're walking into as they are our new generation of healthcare providers. It is a pleasure to be here today. Thank you all for listening. I'm going to come on the screen. If you have any questions or feedback, I am happy to hear it. Hi, everyone.